Healthy Start's webinar. For our second Healthy Start webinar, I'm very pleased to welcome one of the directors of Healthy Start, Dr. Robyn Mildon, to speak about current thinking in how to increase the use of evidence-based practices to support parents with learning difficulties and their children, including strategies for building the capacity of the workforce to properly implement these in a way that fits the context of their service. Now first, some housekeeping. If you have technical difficulties, and you can hear me say this, then you should call Lucy Reid for support. You can call her on 03 8660 3586, and that number is also in the GoToWebinar control panel. As live attendees, you have the opportunity to ask questions of our presenter. To do this, click on your control panel for GoToWebinar. You will see a box where you can post questions. I think that box is called chat. I will encourage you to submit a question here at any time. This presentation will go for approximately 30 minutes, and in the last 15 minutes I will pick out some of the questions you have submitted for Robyn to respond to. Now, at the commencement of question time, you'll see a link to a webinar evaluation survey in your chat window. So if you could click on this link to complete a short survey and feedback form to let us know what you thought, it would be good. If you miss this link, you can complete the survey via a link that will be sent to you via email along with the recording of this webinar and relevant resources. Now, before Robyn presents what will likely be an engaging and informative webinar, I'd like to ask everyone in the audience to reflect on how do we learn to parent? For the majority of parents, the way they plan to raise their children know what skills such as breastfeeding and using formula that they need to learn, and how parents develop confidence in the ability to raise a child comes from two things: how they were raised themselves and learning as they go by learning with baby, toddler, child, teenager at home with family and friends, books, websites, and a handful of practitioners who will be there for a short time. So how does this work for the person who has learning difficulties who wants to have a child? And by learning difficulties, I mean someone who might have a diagnosis of mild or moderate intellectual disability if they have happened to have an IQ test. But really we're talking about difficulties with abstract thinking, difficulties with generating a number of options to problem solve and working out what is best, and difficulties learning by reading something, skills that become harder when you are under pressure. There are a number of examples of good practice in Australia, particularly experienced or skilled clinicians and agencies such as the WIN Clinic in Melbourne, Wansley Family Services in Perth, and networks of individuals working together on issues such as the BOLD network in Brisbane. However, the majority of practitioners who call me do so because they want to refer a parent with learning difficulties to a program that will support them, and they cannot find anything in their area. Healthy Start was set up to increase the capacity of individuals and organisations to support parents with learning difficulties raise their children well. It is a strategy that is funded by the Australian Government Department of Families, Housing, Community Services and Indigenous Affairs, and is jointly run by researchers from the Faculty of Health Sciences in the University of Sydney and researchers at the Parenting Research Centre in Melbourne. Healthy Starts works closely with individuals and organisations to increase their capacity to support parents with learning difficulties. We do this by providing summaries of latest research on the website, compilations of best practice information around certain topics, and we call these practice points, and information about evidence-based resources for working with these parents. We also host an online practice network where members can share knowledge, join groups or co-develop ideas, and we host events such as tailored presentations or a webinar like today. We also work to build the capacity of individuals and their agencies to address the needs of parents with learning difficulties in their area using research and working through it to fit it to their context. We co-develop training programs or presentations, and we look to find and develop leaders in this field that can support these people wanting to be parents who have learning difficulties and may be able to lead some change in their area. So why do we target parents with learning difficulties? We know that parents can do well with the right support that is tailored to their learning needs. However, despite evidence for this, as well as researchers reporting that intelligence or IQ status is not a sole determinant of parenting capacity, this being reported as early as 1947, and other researchers in this field have provided good data to suggest that it is other circumstances surrounding parents with learning difficulties that generally lead to neglect. Despite this, children of parents with learning difficulties are more likely to be removed from the care of their parents, are less likely to be restored to their parents' care, and more likely to be placed in non-kinship care. The disproportionately high numbers of these families who are involved with child protective services is a concern amongst practitioners, researchers, policymakers and advocates in this field. Now, just before I hand over to Robyn, I'd like to run a quick poll just to see who in the audience has heard of Healthy Start before. Perhaps you have attended a workshop before, a conference presentation, or you've read and used materials on our website or even worked directly with us. Okay, I'm going to close the poll now. Thank you for responding. So 47% of you say you know a lot about Healthy Start. I would say these people may be made up of people who are or were a part of learning hubs and basically have been with us since the beginning. It might also probably include those people who have been trained in one or both of the two in-home support programs developed by Healthy Start. 19% of you say you know a little about Healthy Start. So I'd say these people have perhaps seen a previous presentation, read material on the website, or spoken with someone from the team about it. And 34% of you say you have not heard of Healthy Start before this webinar. So our aim for you today is to hopefully start engaging you more with what we do. In fact, a good place to start learning about Healthy Start and best practice for working with parents with learning difficulties is to look through what's on the website. But now I'm going to hand over to Robyn Mildon. Robyn is the director of approximately 15 current projects that sit in the Knowledge Exchange and Implementation team at the Parenting Research Centre. These include Healthy Start, My Time, and the Northern Territory Intensive Family Support Services. For the KEI team's work, her focus is on the use of effective implementation strategies to improve the utilisation of evidence-informed information and practice in parenting and family support and child welfare programs. She also focuses on closing the gap between what we know and what we do by improving the science and practice of implementation in relation to the use of evidence-based practices and programs. Robyn's PhD focused on supporting parents with learning difficulties. She designed and implemented best practice behaviour support strategies to decrease problem behaviour shown by young children of these parents. And finally, Robyn was most recently the driving force in coordinating the highly successful first biennial Australian Implementation Conference, which was attended by over 400 delegates with speakers from Australia, Canada, Denmark, Fiji, New Zealand, Norway, Singapore, the UK and the USA. This conference hosted presentations from policymakers, researchers and practitioners in a broad range of areas, from implementation of new education initiatives to implementation of Australian programs in countries such as Singapore. Now, not to put the pressure on you, Robyn, but we have almost all of our attendees online. So enough of me, and I'm going to hand over to you.
Yeah. Show my screen. Show my screen. Okay, I am presuming that that is working, everybody. So thank you very much for that, Olivia. So welcome all, and this, I have to say, is often a bit of a disconcerting format to present in, just because you have no feedback and I can't see anyone. In fact, I'm out of the office, so I'll give it my best shot, and apologies if I am not clear about something, and feel free to email me later. So the first slide that you should have in front of you talks about who we've got, at least who registered to attend this webinar today. And it looks like we've got a spread that might in fact reflect the population distribution of Australia, I think. But welcome everybody. And for those of you that are new to Healthy Start, I won't be focusing much on the research evidence in terms of how best to support these families. The focus of what I want to cover with you today is what can we do in terms of improving the workforce and the system which is set up to support these families. What can we do to bridge the gap between some evidence that we have that helps us better support families and how we actually do that in services. Because, and this is one of my favorite quotes, and anyone who's seen anybody do implementation presentations before would have seen this. Children and families can't benefit from interventions that they don't receive. So if we just pause and think about that for a second, essentially we might have a bunch of things on our shelves, programs, tip sheets. We may have all been to a lot of training. You might in fact have been to training that somebody at the PRC has offered you. But unless what we find out about and what we learn is used in our day-to-day work with families, they don't actually experience the benefits that research has shown we can have in terms of better supporting them and their children. So it's pretty widely acknowledged that there's a quite a large gap between what we know and what we do. So despite empirical support for evidence-based practices and programs, widespread implementation with sustainment has been difficult to achieve. Implementation provides us a little bit of a way to bridge that gap. What is implemented often disappears with time and staff turnover. Moving evidence-based programs or innovations from a development or research setting to a practice setting with fidelity and good effect involves far more than making these models, these programs, these tip sheets just available. What we do know now, and I'm skipping a whole bunch of research that helps us understand what I'm about to talk about, but we've got this is kind of the brief 101 version, is that to successfully take up knowledge that is research and best practice, it requires much more than one-way communication and one-off training events. And we really internationally, it's acknowledged now that we need to genuinely interact with everybody who's involved in the system in terms of how can we embed what we know and improve that to improve outcomes for children. So we need genuine interaction among researchers, decision makers, and other stakeholders. And we need active and purposeful and planned implementation activities. And this is a real learning for me, that really to implement something, that is to do whatever it is that you set out to do in a planned way and do it the way it was designed. Implementation success cannot occur without some change. and that change is difficult. So if we are sending our practitioners to training events and asking them to do things differently with the way that they work with families, firstly, that's difficult. Doing things differently is difficult. But also the systems around the frontline workers need to change to support them to do something different. So asking somebody to behave differently and sending them back into an office and hoping they just do that, things kind of in hindsight a bit ludicrous. So to get the most out of what we have, we need a what and a how, and we need to pay attention to context. So in the context of parents with an intellectual disability, our what are the evidence-based or evidence-informed programs and promising practices that are available. And that's one thing that we're quite proud of on the work we've done on Healthy Start since the initiative was first funded by the government, and that we think we've made quite a headway at least disseminating what's the state of evidence in terms of best practice for supporting these families. The trick now is to get this actually used in practice, used in a thoughtful way, including data to measure how well we're doing, and then using that data to further improve on how we're supporting these families. So that's where the effective implementation frameworks come in. And these are strategies that change and maintain behavior of practitioners and create hospitable organizational systems. So really what I'm going to talk about could apply to all sorts of families that we work with. But I would ask you to keep in mind these particular group of families, given their high level of vulnerability and much an overrepresentation in the child protection system, just based on misconceived perceptions that just because somebody has an intellectual disability means they will be incapable of parenting. And the one thing I do love about focusing our work on parents who have an intellectual disability is there is research and best practice that can help us. And it does help them, and it does help them to keep their kids and keep their kids at home and keep their kids in a healthy and safe place. Oh, sorry. The last point I meant to make there is we also need to pay attention to the context. So that is the systems or the agency or the setting that these services are delivered in. And I'll talk a little bit about that. But here's a few definitions first. All right. Generally the field, and when I say the field, I mean parenting support, early childhood, child welfare, child protection, health, everybody in the human services area has over the last 20 years come to understand that there are these things out there called based programs and practices. And the main strategy we've used or relied on to be able to get that used in practice has been dissemination. So dissemination is circulating or presenting research findings to potential users in formats that may be more or less tailored to their target audience. It assumes a one-way flow of information from research to practice and views research users as relatively passive consumers of evidence. It's really important to get that bit about dissemination. When you're doing dissemination activities, we really would assume it comes from an assumption that you have a lot to say, like I do right now, and I'm just going to say that to you, and I'm not going to get much feedback back. So it's kind of a classic conference model or a tip sheet or a website or even a webinar like I'm doing now. It has a place, dissemination, but in and of itself it's not, it is inadequate. So then we go to starting to, so the field started to look at other strategies you could use to bridge the gap between evidence and practice. And people start to talk about knowledge translation and exchange. And I kind of imagine this as an increased continuum of effort and activity. So knowledge translation exchange gets at a more interactive interchange of knowledge and activities between researchers and users and producers of research. It includes production and utilization. It assumes a two-way flow of information among researchers, decision makers, and other stakeholders. So this is where we're getting our messages from research, but we're translating much harder, in a much more thoughtful way for the audience that we're trying to reach. And we're also, in a much more planned way, interacting between the people that traditionally produce research and those that would traditionally use it, and almost trying to bring them onto equal playing fields. And it involves some very hard and facilitated two-way information flows at times. And obviously it creates a little bit more effort that needs, well, it results in more effort needing to be made to translate and exchange that information rather than writing a tip sheet. And then we step it up again when resources permit and the goals of whatever you're trying to achieve, we step it up to this idea around implementation. And what we mean by that is the planned and intentional use of strategies to put into practice evidence-informed programs, sorry, that's what EIP means, within real-world settings. And the important thing to get about this slide is that implementation is a process and not an event. And it should be distinguished from adoption, which is often defined as just a decision to use an evidence-informed practice or program. So that's really important. Just making a decision to use a particular approach with families or within your service isn't implementation. It's just making a decision to do it. Whereas implementation involves planning and the use of intentional strategies with the aim to really embed that within the service and to measure whether or not we're getting the same effects that program or practice may have got in a clinic setting. Now, implementation science, which people are talking about more and more, is really the study of methods to promote the integration of research findings. So it's really the study of doing implementation, figuring out what worked best, what could we do next time. So the thing that's helpful when we think about the aim of Healthy Start and how can we embed what we know now effectively, fully, and sustainably within the service sector that has been set up to support these families and other families that are vulnerable, or just families that are coming and asking for some help. And one of the things that's emerged recently in the last 15 years of implementation research is this whole idea behind a framework for implementation. And this describes the process of doing implementation and provides an overview of the practices and guides the activities and behaviors you would want to see or do when you were focusing on implementing something effectively. And the nice thing about it is, if you go back to the idea that emerging research is telling us we are more successful at embedding research and practice into real-world settings when we do genuine knowledge exchange between all the stakeholders involved. The thing that implementation frameworks allows you to do is work together collaboratively with a team of people possibly coming from different places and go through a series of phases and activities within these phases that have been shown in other studies to improve the implementation of what you're trying to embed. So for this sector, that is child welfare, parenting, child protection, early childhood, family support, there are essentially 3 frameworks that apply. Now, there are about 27 frameworks that exist in the literature. Most of them were developed for the health sector. But these 3 I find are useful in work we do with agencies and government across Australia. The Quality Implementation Framework is the first one I'm going to briefly show you. Then next we'll be taking you through some work that a group called the National Implementation Research Network did, and then briefly showing you some work that has been done by a group who developed the Getting to Outcomes framework and how that's influenced us. But the important thing here is if we think about the first one, the Quality Implementation Framework, the authors of this framework did a really nice job of synthesizing all the other implementation frameworks that have ever been published and and produced back a consolidation or a synthesis of, if you like, of what all the other frameworks were saying. So the QIF has 4 phases. You can see phase 1, 2, 3, and 4 there. And within each phase, it has steps. Now, all implementation frameworks have phases and steps. So that's good. So you can see some familiarities across them. So in the QIF, the first phase focuses on getting what they call the host setting ready. And the host setting can be the service, it can be a whole agency, it can be a government department, it can be anything. In the work we do, it's most commonly the service within the agency that we're trying to support to improve their practice. And you can see there's 8 steps that the QIF authors say most frameworks address. Now, you don't need to do all of these, but you can see it's very thorough in that it looks at a needs and resources assessment, it conducts a fit for assessment, it looks at the capacity or the readiness of the practitioners, supervisors and managers within a service. How ready are they to do something different? Do they even think it's important? And takes you through a whole series of components. It then moves you into phase 2 where it talks about creating implementation teams. There's some really nice emerging literature around the importance of implementation teams in helping drive the implementation of anything. And there's a couple of studies we could share about there, and there's a whole way that you sort of facilitate and use an implementation team. That's interesting, and we do it often in our work at the PRC. Develop an implementation plan on all the decisions you made in phase 1, and move through to actually implementing that implementation plan. The important thing to notice here is the time spent in getting the host setting ready, which is very similar to this cycle here that we apply often. This was a day. That's very similar to the QIF's
Robyn, sorry, it's Olivia here. We just lost you for about 5 seconds, just when you went to this slide on the knowledge to implementation cycle. Could you step us back from that?
I'll step back. Okay, so I'm at the knowledge to implementation cycle. We apply a lot in our work in the PRC, and it was adapted from the work of the National Implementation Research Network. And you'll see they talk in phases, similar to what the QIF talks about. But the thing to notice is the orange box there on the outside to the left that talks about development and adoption, that's similar to what the QIF says in terms of getting the host setting ready. And our friends in implementation in the US coin this as pay now or pay later. So doing the initial upfront thinking and planning and stepped out readiness checks and engaging the key stakeholders is essential. And in the work we've been doing over the last couple of years, including the work that Olivia and the team are doing on Healthy Start, that is vital. And in fact, when working with teams, that compulsion the sector has to go to training really quickly, we've really found, and it's essentially reinforced in the implementation science and knowledge exchange literature, but taking the time in the beginning to really figure out what outcomes you're trying to achieve, what does the evidence say about that, and how can we get the setting ready to do that, pays off big time later in terms of being able to effectively implement what you're trying to achieve and improve outcomes. You'll notice also the knowledge to implementation cycle goes into an installation phase. That's the planning and preparing what needs to be put in place, again, similar to phase 1 of the QIF. And none of this ever happens in this tidy fashion in the way that I'm presenting to you. Often we might be doing the orange box, the installation phase, and the early implementation all at once, especially given the sort of service contracts that the sector needs to deal with. But the next most vital thing here is within all these phases, the literature has managed to be able to pull out what are the core components that need to be addressed when you are focusing on implementing and changing systems to better embed evidence-based practice and programs. And that's the triangle that you're looking at there, which again has been developed by our colleagues at the National Implementation Research Network in the US. So they talk about implementation drivers. You'll hear me talk about implementation components or essential components. I think the language fits a little bit better for our side of the world. But on the competency drivers or competency components, you'll see selection training and coaching there. Now, selection is referring to staff selection. And what that's getting at is figuring out if you have a particular evidence-based program or practice that you want to implement. What actual skills do people need to be able to implement that? And actually putting that into your position descriptions and hiring for it. Sounds simple. A lot of us don't do it. However, unfortunately, in a lot of settings, we can't hire for what we need. So a lot of places in Australia where Healthy Start and other PRC projects support the sector, we may need to implement quite a complicated clinical program. But recruiting for staff to do that in those local areas is difficult. So what we do is we overcompensate with the training and the coaching drivers. You'll see in the middle of that triangle it talks about these are integrated and compensatory. That is, if you can, you'd want to try and address all of these components. However, if there are certain things you can't do anything about, like staff selection, and you basically need to develop the skills of the people you have, you overcompensate for that with you applying your training and coaching driver. Over to the other side there, and something that really, since the emergence of implementation science has been quite relatively new, is doing some planned and conscious work around the organizational drivers. That is the infrastructure that is around the frontline practitioners and the supervisors that is essentially there to support them to do their work. Because really, all of these components are all around enhancing people's practice and performance, which are all in the honor of improved outcomes for children. So on the other side there, we talk about systematically addressing any systems interventions, that is, other people that we're partnering with, referral pathways, key stakeholders outside the agency that can have an impact on implementation. We talk about facilitative administration. That is the practices and policies that are in place in an agency that can either help or hinder the implementation of something. It's often somewhere that we forget to look. And this really, really important one around using data to, A, figure out what are the best programs and practices to implement, B, see how well that an agency or an organization is actually implementing, and C, measure the outcomes. That is, are we actually achieving the outcomes we set out to achieve, and if not, what can we do better? So using data to drive the decision support system is important. And then you'll see leadership as embedding the whole thing underneath. So this slide here is related to the Getting to Outcomes framework. It was the third framework that I referred to in the beginning. And this really starts to give you a flavor of what needs to be changed within a system to better embed and support evidence-based practice. So if you start from the left-hand side there, we talk about achieving desired outcomes. So for instance, on Healthy Start, the team try to work with people all over the country to, when they're asked the question, hey, do you have training in a particular program, Olivia and the team try to focus on first talking with people about what it is that they want to achieve in the first place, and then matching back as to what would be the best way to do that. And it may be a practice or a program that Healthy Start has that we're able to support people to use, or it may be something completely different. You take those outcomes into account and you look at the current level of capacity of an agency. And then within that you can see the GTO steps, so the Getting to Outcomes steps. This is a group in the US that have been working on this for a long time, and all of this is available free on the internet for the RAND Corporation. Getting to Outcomes takes a series of decision-making steps about, firstly, what is your what? What's your best evidence-based program or practice approach going to be here? And what do we do? What do we need to do to truly implement it? And you can see GTO here is getting at wrapping this kind of systems of support for an innovation and evidence-based program practice, anything. So it talks about the need for tools. So that would be your manuals, your tip sheets, your policy documents, your service manuals, anything. And one thing I have learned in terms of changing systems to better meet the needs of children and families is the more we write down, the more we document about what we do, the better off we are later. the less we do, the worse off frontline staff and their supervisors are in using new practices, and more likely we are to see practices being used that either have no effect or could possibly be doing more harm to the families. So you wrap the tools into a training plus model. So the important thing to say about training, and I should have said this, sorry, at the triangle slide, is training plus is referring to a training plus coaching model. And the evidence for the effectiveness of coaching to support practice is overwhelmingly strong. The evidence for how ineffective training is by itself to change practice is overwhelmingly strong. That is, no matter how good a training program is, we now know, and there's tons of studies to show this, that it is necessary but insufficient in changing people's practice. So we talk about a training plus model, a training plus some in-field or case review type coaching to help people use those strategies in their day-to-day work. We also talk about TA, other technical assistance that you can draw on to help agencies, and this isn't again just about changing frontline practitioner behavior. This is about supporting them to embed evidence-based research programs and practice in what they do, and supporting the people that support them to do that. So again, looking at what supervisors are doing, looking at what kind of coaching we can embed, and then taking it a next level up. Supervisors and practitioners supported by managers within an agency. So what are we doing there to help embed these programs and practices? So everything's kind of lining up in honor of this what we call it. QI and QA, that's referring to quality improvement or quality assurance processes that can be and should be embedded within a service. Practitioners, in our experience and everybody else, are certainly not going to collect or share data that they don't see as helping improve what they're doing and don't see has any meaning. Very nice thing about the emerging area of implementation is it has a strong focus on that data decision driver, just data decision-making driver, in that it focuses on how can you use data, and you should use data to put yourself into a continuous quality improvement, quality assurance process. And all of that kind of wraps around your what, which is in the middle with the GTO steps, to equal actual achievement of outcomes. And the last point is context matters. So all of this is all very well, putting all these things in place, using increased knowledge exchange, ways of working together, and applying what we know from implementation. But we all work within a context. And this study here by a guy named Gregory Ahrens, and sorry, the reference has dropped off the slide there, so I need to put that back in. But this study was published, I think, in 2010 by Ahrens et al. And they looked at the relationship between organizational support for evidence-based practice, attitudes toward evidence-based practice, and the use of evidence-based practice. Now, this is highly relevant for initiatives like Healthy Start, because we're all about trying to support the use of evidence-based and evidence-informed practice in day-to-day work. And what Gregory Ahrens found, this study was done in the US, was there was a gap between the public and private sector in terms of innovation and implementation. So public being like our government and private being our not-for-profit sector here. He found that private agencies provided greater support for evidence-based support for implementing evidence-based programs in practice, and that staff working in these agencies reported more positive attitudes towards adopting them, and that organizational support was significantly positively associated with attitudes. So that is, if an organization was supportive and made it possible for people to access evidence, think about evidence, use evidence, their workers were more likely to have a positive attitude towards it, and therefore more likely to be using it. That makes sense, really doesn't. He also found that if an organizational context was positive and supportive in terms of using evidence in practice, they were, but practitioner attitudes towards it were negative. The context of the organization sort of overcompensated for negative attitudes, and it still meant they were getting high rates of implementation of evidence-based practice in that context. And this slide's just for fun because it shows you how much context matters. That big bubble up the top there is a result of a work myself, colleagues have done on a project we're doing in the Northern Territory. And what that's showing is no matter how good we do the bottom part, so you'll see the program and service we are trying to put in place. You see a list of all the implementation support strategies we are trying to use to embed that program and service. And you'll see the way we're measuring both our implementation outputs and our program outcomes. But no matter how good we do all that, there are these moderators in the environment, in the context, that we need to be aware of, take into account, and hopefully measure what kind of impact they have. It doesn't mean we won't achieve what we're trying to set out to achieve, but it means we need to be aware of these and find some way to monitor them. And the final thing I wanted to just talk about, which is a really big issue when trying to move things from clinical or research settings into the real world, is this whole idea around fidelity and adaptation. So when we talk about fidelity, we're talking about three things really now: exposure, adherence, and equality. So fidelity basically is trying to get at how true to the original program developer's model do we stay to when we move programs and practices into the real world. And how you measure that is by measuring the fidelity in which people implement those things. So we talk about exposure. Was the amount of the intervention that is offered to the participants in relation to the amount that was prescribed by the model? So do the children and families receive the amount of the intervention that the program developer said they should? Adherence is getting at the extent to which techniques and practices were delivered according to the specifications. And the quality of delivery is focusing on the practitioner or manager's performance on dimensions that they thought would enhance the delivery of intervention: enthusiasm, style, ability to facilitate people's participation. The quality measure is new to the fidelity adaptation debate. We've been a bit late coming to the quality of practice. A lot of you would be quite unhappy to hear that. But we do now have a really good look at the quality in which people are delivering and see the effect it has on the quality of practice. But one of the most critical challenges in implementation of evidence-based programs and practice is this tension between adaptation and attaining fidelity. Because no matter which way you look at it, everybody changes it when they put it into the real world. And in fact, probably so we should. And in the work that we do on Healthy Start and the other exchange and implementation work we do, we concentrate and deliberately pay attention to what will need to be adapted when we move it into a real world. How is context going to impact it? But how can we stay as close as we can to keeping the core components of what seem to have the effect of that intervention so that we can also achieve those outcomes and maybe even achieve better ones. So adaptation is to make fit as for a specific or new use or situation, often by modification. And this is just to show you, this is really hot off the press. A very smart guy has been trying to figure out another sort of implementation framework, if you like, to help guide decisions about adaptation and how we can strike this balance right between fidelity and adaptation. And he's come up with a thing called the dynamic adaptation process. This is Greg Aaron's work again. It has 4 phases for implementation. So again, you see that phase team coming through. Takes into account the multi-level context of service delivery. Service delivery just doesn't happen by one person in one spot. Organizations have multiple layers in them. It engages multiple stakeholders, and it provides expertise and feedback during implementation. And there it is, which is sort of a mean slide to finish on. But I'm really excited about the possibility of what the authors are thinking through here, because you see it still has that exploration phase, that pay now, pay later phase, where you're looking at all the different levels of a system and getting them ready to implement. You move into your preparation phase and your resourcing and implementation team. You can see you have the two-way kind of exchange happening with all the key players there. Moving out into implementation phase, the sustainment phase, ongoing feedback loops are all totally dependent on using data. So just to finish on that, I think, Olivia, that was my most complicated framework I wanted to finish on.
That's great, Robyn. Thank you. Look, it's 4:15 at our end time, but I was keen to not interrupt you because it was very important and useful, I think, to hear about all of that information that you prepared. So thank you very much. There is a chance if someone has a real burning question, you're welcome to send that through on the question panel on your GoToWebinar control. If you want to continue discussion after this time, because I am keen to stick to our end time of very soon, where you can continue this discussion on an online discussion on the Online Practice Network, which you can access via our homepage, which will be on the next slide, but I'll just verbalise it for you. Robyn, could you keep that slide up for now? Thanks. It's www.healthystart.net.au. A copy of the slides from today will be posted on that online discussion and the recording as well. Now, just to reiterate, to provide some feedback on today's webinar, we'd really love if you could fill out our online evaluation form, which should take you about 2 to 3 minutes, and there's a URL link I've just put into the chat panel to everyone now. So I don't think there are any burning questions. We can follow up with people individually. Thank you to those people who have asked about the slides and prompted me to say that, so that's good. Robyn, thank you very much for providing such a good insight into the model for how to get best practice a part of daily practice for individuals and agencies. And in terms of where to from here today, we have a next slide, if you could flick to it now, which has 3 calls to action that you could consider. So to stay informed about latest research and stories from the field and events, subscribe to our e-news, which you can do so via our homepage, the link's there. To skill yourself further in best practice approaches for parents with learning difficulties, feel free to look through the material available on our website and then start sharing ideas with others via the Online Practice Network. And if you'd like to have further discussion about your individual needs or your organisation needs, please contact us directly. So thank you. I'm going to end the webinar now. I hope everyone has a very enjoyable day, and thanks once again, Robyn.